Yeah, if anybody has any questions as we go along, let me know. Thanks for giving me this opportunity. So we'll share some of these cases. Some of them are more recent that we've had, and then some are from several years ago. And go forward. Let's see. There we go. So I don't have any disclosures. So, you know, EEG is very important. And, you know, when we're trying to figure out what's causing epilepsy. So Epilepsy Demographics among children. So lots of kids each year have a first-time unprovoked seizure. The lifetime chance of anybody in the population having a single seizure is about 5 to 10%. And then the epilepsy in the general population is about 1 to 3%. So lots of people running around out there with epilepsy. So epileptogenesis, that's when the normal brain starts producing seizures. Lots of different ways this can happen, lots of different mechanisms for this. A lot of it has to do with ion channels changing or neuroreceptors changing, which can be genetic, due to genetic causes, and network reorganization. So loss of cells here, different cells here, connections sprouting here and there, due to injury or you know, tumors or what have you. So complicated things. So causes of epilepsy, there are a lot of them. So as you know, we play detective. We try to put the pieces to the puzzle together to try to figure out why somebody's having seizures. And EEG is a very important part of that puzzle. So the focus of this talk, I'm just going to present some cases and the EEG findings, and then I'm also going to discuss some of the kind of causes and, you know, the pathophysiology behind some of these seizures. And I wish we could do video. I did check. I checked for a different talk at one point just about HIPAA and things like that, because, you know, it's so much better when you have the video and can actually see the seizures. Epilepsy is so visual, but we'll do our best. Maybe no, I won't act out some of this stuff, but, you know. So case 1, patient is a 2-year-old child with intractable epilepsy. She presented initially as a really young little girl, 7 months. She had febrile status epilepticus at that time. Initially, it was just chalked up to, you know, sometimes children do have febrile status epilepticus, but she, over the next few months, presented a few more times in febrile status, and seizures could last as long as 30 to 40 minutes before the status could be stopped. She started on Keppra, but continued to have frequent seizures. So Trileptal was started as well, but this seemed to worsen things. So Onfi was started, and seizures did seem to decrease in frequency. Initial workup, she had normal brain MRI, normal EEG, so nothing to work on with that. She did have a comprehensive epilepsy panel sent, and an SCN1A variant was found. So the question was, does she have Dravet Syndrome? Because that's what SCN1A is associated with. But that, she was rather young at the time, and development was normal, and so we weren't sure. But over time, she did continue to have seizures, some without fever. She started becoming more off balance and was not developing speech really well. So it looked like she was going towards Dravet Syndrome, which includes intractable epilepsy, this pathological variant in the sodium channel, and then also abnormal development and some regression at times. So she is on the medications Epidiolex and Onfi and Keppra and valproic acid, and then planning on doing a vagus nerve stimulator. She's interesting because, so here's her EEG, the interictal part. She really doesn't have many, for as many seizures as she has, and as severe as they get, she really doesn't have that many abnormalities, just a few here and there. And that's really what her interictal looks like. And, you know, maybe a few more during sleep. But then this is when her seizure, when she has a seizure that we captured in the EMU. So she has just kind of, we're going along here, we're awake, we're doing our thing, and then suddenly just broad onset seizure activity with stiffening. And this one only lasted a few minutes. But yeah, Dravet syndrome. So a lot of these kids present with just febrile seizures, and that's often what we think is going on initially. Oh, it's just a febrile seizure. But it can get more serious depending on how severe or what type of mutation they have in that sodium channel. So initially, Dravet syndrome was called severe myoclonic epilepsy in infancy, but they noticed that some of the myoclonic seizures and the epilepsy persisted into adulthood, so they did change the name to Dravet syndrome because it was described by Charlotte Dravet in 1978. Usually, they present after they've been healthy kids, developmentally normal, and there are 3 phases to this syndrome. So the febrile phase, where you think it might just be febrile status or febrile seizure, they call it the catastrophic phase, and that's just when you start having some developmental delays and regression, and then you kind of hit the steady state where you're just you stop going backwards and are just stable. So the febrile phase, usually you catch those kids pretty young, 5 to 8 months old, but they can be older. Seizures can be generalized or focal, but they do tend to be long, which is one of the a tip off. So 20 minutes or so for status epilepticus. It can also occur without fever, so just something that triggers them, either a vaccine, not that we shouldn't vaccinate, illness, or even a bath. So temperature sensitive, the bath was hot and then they had a seizure. I looked for an example of this but couldn't find one, but some of these children will have at a young age, we'll have like a photo stimulation response, which is a little bit unusual in such young patients, because usually we see this in like juvenile myoclonic epilepsy, and so just a little unusual for that age group. I mentioned there's the catastrophic phase where you get further seizures, and then slowing of development. And it's hard to know, the epilepsy and the repeated seizures may also contribute to this. And they can have all sorts of different seizures, you know, generalized or focal. And then we've seen seizures, I'm sure, in the EEG monitoring unit where they start on one side, they go to the other, and then they come back to the next side. And so, yeah, just lots of seizures, all sorts of different types. Triggers for seizures in Dravet syndrome children are interesting in the sense, you know, if we think about it, in the initial phase, they can present with febrile status, so they are rather temperature sensitive. So baths can trigger, and some of them will have more seizures in the summer or in hot regions. Other triggers, we mentioned the PPR that you can see on EEG sometimes, so kind of light and photosensitivity can bring out a seizure. Anything with like contrast, so television in a dark room or strange designs on a wall that seem to stand out can visually trigger some seizures. And then we mentioned kind of the developmental regression. So, you know, some children are very hypotonic when they're younger and then ataxic. You can also see some myoclonus or some autonomic symptoms, so sweating and tummy troubles, and sometimes some fluctuations in heart rate. And then language can really kind of regress. And some of them have autistic traits that don't quite meet the criteria for autism spectrum disorder. Usually MRIs are normal or might show some atrophy after you have a lot of seizures. And they can have hippocampal sclerosis as well, which after a period of time, which we do know it. Some kids who have a history of febrile seizures also have hippocampal sclerosis. So the hippocampus is probably just very susceptible to seizures, and then over time being damaged due to seizures. Usually there's at least some sort of family history floating around of febrile seizures, though 25 to 71%, that's a big, wide percentage. A lot of them can also just be a new onset mutation. And there's not really been a mutation found that results in a more severe case of Dravet syndrome versus not as severe. So SCN1A, it's a protein, it's a channelopathy, so voltage gated sodium channel. And they play a role in action potentials. So when these are altered, it goes towards neuronal excitability, or it leads to, you know, the neurons are more excitable and not as inhibited as they should be. So with these kids, we're very careful, kind of like our patient, she was started on trileptal, and that made things worse because sodium channel blockers, which actually are the, I'd say more epilepsy drugs are sodium channel blockers than are not. This can worsen seizures. It's not completely understood why this is, but it could be if a lot of your sodium channels aren't working real well to begin with. When you go to block them, that just further decreases the inhibitory circuitry. So the inhibitory circuitry is the circuitry that's putting the brakes on seizures and too much excitability. And so when you block that, you just make everything more excited and cause seizures. Epidiolex was a big, they studied children with Dravet for Epidiolex. And so it was approved for Dravet when it came out. And then so other medications you can use are Depakote and benzos, Keppra, Topamax, stiripentol. We don't use it a whole lot at our institution. You have to be registered to use it, but it is another one that can be used. And then we also have ketogenic diet and vagus nerve stimulator. So the thought is that when someone starts to go into possibly a long seizure and go into status epilepticus, you can swipe the magnet across the vagus nerve stimulator and hopefully prevent status. So overall, you're a little bit more cautious. That's not just a febrile seizure when somebody is younger than age 1, has some like one-sidedness to their seizures, and the fever wasn't really that high when they presented. And then also if they have really long seizures, especially if it happens over and over again. All right, case 2, and this is a recent case at our hospital. A 5-year-old boy from the Amish community presented with new onset seizures. Per his mother, he'd woken up from a nap and seemed to kind of zone out, and then he stiffened, rolled eyes back. Seizure lasted a few minutes, and so he's taken to the hospital where he had another seizure. He was then transferred to our hospital for further care. Interestingly enough, it was noted that he started wetting the bed, which was uncharacteristic for him a few weeks prior to his presentation. So there is some concern that maybe he was having seizures at night prior to this. He did have a slight developmental delay history. Per his parents, he was just a little slower to walk and talk than their other children. And then on physical exam, he just had a few features, maybe a little more wide set eyes, and just looked possibly a little dysmorphic. So all these things bring up concern for genetic cause of seizures, just a little dysmorphic, little developmental delay. EEG showed slow background, no posterior dominant rhythm, high amplitude generalized frontally dominant spike wave discharges, also some left temporal discharges though, and then seizures that seem to be both focal and generalized in onset. So you're wondering if he's developing like a Dravet type, or not Dravet, I'm sorry, Lennox-Gastaut type syndrome, or where this is going. So there was concern that there's a genetic etiology. And here is an example of generalized discharges, so about 1 hertz. And then some left temporal focal discharges right here. And then here's one of the seizures. This one is it looked more generalized in onset. So we see this onset right here with this wave, and then kind of a tonic stiffening, but then you get this kind of focal, it looks more focal over the left frontotemporal area. So just kind of a strange picture. Is this focal? Is this generalized? What's going on here? Is it both? So that's kind of what we were thinking, or what those taking care of him at the time were thinking. It's just, people talking amongst themselves. We go ahead and order genetic testing, but, we'll get the MRI, obviously. And the MRI showed this inferior left frontal lobe subcortical white matter tumor. So this was interesting because I do, the people taking care of him really thought, this has got to be genetic in nature, but this is a huge tumor. And it's in the frontal lobe. Tumor resection, and it was a DNET per pathology, so a low-grade tumor. So I thought this was an interesting example of you can get, especially if there's a lesion in the frontal lobe, you can get bilateral, you can get secondary bisynchrony. So you can have a unilateral lesion, but it leads to what look like generalized epileptic discharges just because of the circuitry, so you can get fooled. And then low-grade tumors are more likely to cause seizures than high-grade tumors. Low-grade tumors, usually in the frontal temporal parietal lobes, usually rather than occipital tumors, present with seizures. And a lot of these seizures are going to be intractable, even at onset, first presentation. So DNET stands for dysembryoplastic neuroepithelial tumors. That's why we call it DNET. And they're typically associated with epilepsy that's hard to treat. They think that low-grade tumors are probably epileptogenic due to overexpression of neurotransmitter receptors and inflammation that goes with that. All right, case 3. So let's see. We had this is from a few years ago, a 13-month-old boy with history of developmental delay, presented from an outside hospital with status epilepticus. His mom noticed some twitching of his right arm. He had fever. Later, his mom noticed that he seemed uncomfortable, and then his eyes rolled back and he had full body, she described more of a shivering rather than tonic-clonic activity. This would occur for several seconds and then stop for a few minutes, and then it would start again. He was taken to the emergency department, and he's recognizes seizure activity, and so he received Ativan and Keppra and phenobarbital, and this all made him a little sleepy, so they had to protect his airway and intubate him, and then he was started on a Versed drip. Part of his workup, he got a brain MRI and a brain MRS, which were normal. It was very strange. He had, looking for infection. Could this be an infectious etiology? He presented with fever. The lumbar puncture that was performed, the spinal fluid studies looked normal, except for this really, really elevated protein, which is unusual. And so that was just kind of a clue towards what might be going on. He did remain seizure-free and could get off all the IV meds and get extubated. The neurotelemetry was stopped, just Keppra was continued. But while he was still in the hospital, he was noticed to have these strange myoclonic jerks. And then also he had increased reflexes, which was just kind of odd. Neurotelemetry was restarted, and there didn't seem to be any EEG correlation with the myoclonic jerks. So he was started on Klonopin for the jerks, just thinking maybe it's myoclonus, but the very concerning type finding. So genetic testing was sent and was pending when he was discharged. He continued to have very frequent myoclonic jerks at home, and obviously this is very concerning to parents. They noticed that jerks became a little bit more in his right arm and twitched. They did bring him back to the emergency department, and he was found to be in focal motor status epilepticus at that point. That right arm twitching just wasn't stopping and was very rhythmic. So he was given a lot of medications and intubated, and after trying different things, a pentobarb coma was started. So this is kind of what the focal motor status looked like, the Epilepsia Partialis Continua. So with each of these waves, you see his right arm jerk, and it just keeps going, and this was like hours worth. So he was put in a pentobarb coma, so we've got good burst depression, and then every time the pentobarb was weaned to try to get him out of the coma, focal motor seizures would come back, and so you just see these spike wave discharges that correlated, as someone has correctly documented, right arm jerking. And they just continued. As you can see, all the pink marks up here is him having the focal motor seizures. While he was in the hospital, the genetic testing did come back. He was found to have one gene from mom and one gene from dad, so autosomal recessive, for a mutation in a gene called POLG. Given the patient's age and him not doing well, it seemed consistent with what we call Alpers syndrome. The family was counseled about the poor prognosis of this disease. As I mentioned, attempts were made to wean the pentobarb, but the seizures just persisted. So the focus of treatment was then changed from treatment to comfort care. So POLG, or Alpers, it's interesting. Unfortunately, we do see kids present with it, I'd say probably at least once a year on average. So POLG, that stands for polymerase gamma, and so it's a little enzyme that helps repair mitochondrial DNA. And so the mitochondria are what's making all your energy for all your cells to use, and so that's a very important little enzyme. Mutations, because they're not fixing the mitochondrial DNA well, this slowly decreases just energy available. And so neurons become stressed over time, and this leads to neuronal death. And so that's kind of where our developmental regression and the seizures come from. And so epilepsy is a very frequent feature of POLG disorders, especially in children. So adults can be walking around with a POLG mutation as well and not have any problems until they're older. They tend to present with, they can present with seizures, but they tend to present with some other findings. But in children, it's about 80% will experience seizures. And so Alpers is just basically a name for this early onset epilepsy with developmental regression. And the liver is very much involved in this disease. So you'll start to have elevated liver enzymes. And you can have myoclonic seizures, and then Epilepsia Partialis Continua, and then Generalized Status Epilepticus. And seizures are generally very, very hard to control. We are always very careful not to use valproic acid in children under the age of 2. for this reason. Valproic acid in these patients can induce liver disease that is fatal. And so at our institution and at most institutions, children who present with myoclonic seizures or in status under the age of 2 years old, we don't use valproic acid unless they've been tested for POLG. Okay, case 4. So this was a 5-day-old girl who presented to the hospital after having really severe apneic episodes that were suspicious for seizures. The event started when she was about 3 days old. Parents were describing just body tensing and stiffening, her eyes rolling back, and then some lip smacking. They were seeing this last seconds to minutes. And so that's when they brought her to the hospital. She was a full-term baby, born by electively induced C-section. Mother did have HSV and was on acyclovir while she was pregnant. And this always just makes you worry a little bit about HSV. Her family history, no family history of seizures, just lived with mom and dad and brother at home. In the hospital, she had 3 very similar looking seizures lasting 1 to 2 minutes, where she did become apneic with stiffening. The seizures did stop after Keppra and 1 load of phenobarb. And so they're pretty easy to stop. We were very worried at first, but the seizures were pretty easy to stop. And so she was just hanging out on Keppra and doing well. So here's just EEG footage of what we were seeing with the seizures. So we'd see this, just this kind of out of nowhere wave come, and then kind of some stiffening, and then we'd see this more rhythmic activity. And she would just kind of turn her head to one side and stiffen and stop breathing. So this continuation of the previous slide, and just this rhythmic activity, just increase in amplitude and keep going. And then we'd see some mouth twitching or mouth movements. And then it'd slowly kind of decrease in frequency. And then we'd get just this diffuse low amplitude activity after the seizures. And each one looked the same. So at this point, we're worried about a very severe infantile epileptic encephalopathy. You know, is this O'Hara? Is this what this could be something very bad. So MRI, MRS were normal. She did get a lumbar puncture for CSF studies, just mostly due to mom, or pretty standard, but also there was concern just with mother's HSV history. And then also had metabolic workup, which was all pretty normal, a little elevated ammonia, but nothing that stood out. Genetic testing did show a KCNQ2 mutation that came from mom. And this is for benign neonatal seizures. So this was good news. It's not anything that, we do have kids who have O'Hara or something really bad where, life expectancy is very short. But this one was benign neonatal seizures. And so this happens in term infants, usually normal pregnancy and delivery history, a little more common in boys than girls, but even though our patient was a girl. Usually seizures occur between the 4th and 6th day of life, which is why it's been called the 5th day fits in the past. Her seizures pretty much followed the typical seizure pattern for this type of benign neonatal seizure activity. And usually you do get the genetic testing, but a lot of this is diagnosis of exclusion. You want to make sure nothing else bad is going on. And it's good prognosis because usually they just, like this patient followed up with me, over the course of time. And then about 6 months ago, she was a year old and off her seizure medicine and doing great. So it went away. So usually it does come from a mom or dad, even though they are not symptomatic. Like I said, she followed it to a T where she had brief apnea, followed by autonomic manifestations, just some lip smacking. And then, yes, seizures stop within 1 to 6 months. And her background also followed this to a T, where you have the generalized flattening of the background, focal or generalized spike and slow waves with the clinical manifestations, and then prolonged flattening of the EEG following the seizure. So if we go back to the EEG, we can see that again, where we do have the flattening, and then the focal appearing generalized at times, spike wave discharges, which spread out and become less frequent, and then diffuse slowing at the end. So very, she was a very, actually when you look back at her, she was very textbook actually for benign neonatal seizures. Okay. Oh, and that's all I have. Any questions?
Dr. Conrad, you did a great job. Thank you so much.
Yeah, thanks for listening. I appreciate it.
Yeah, I really liked the part about the benign neonatal seizures, because I feel like, I don't know, a lot of the EEG examples I can remember from being involved with monitoring them, but I feel like the neonatal benign seizures, they're not very common.
Mm-mm.
Right? So it's nice to have a refresher on that, for sure.
Mm-hmm. Yeah.
Does anybody have any questions before we let Dr. Conrad enjoy the rest of her Saturday? All right. Well, if we think of any, we may send you an email or something like that. So thank you so much for sharing.
All right. Thank you all for listening. I appreciate it. All right. Take care.
Thank you, Dr. Conrad. Okay, guys, we're going to just, I'm going to give a couple updates, just a few updates if you joined us late. We're early, so it's 11:26, and so we have some time. We actually put in a lunch break between 12 and 12:30. So we'll probably just go ahead and take a lunch break now so that we can stay on time. So we'll take I guess an hour now lunch break. We will reconvene at 12:30 with Dr. Miller. So just a few quick updates before we disconnect here and see you back at 12:30. But if you have questions, please type them into the chat box. I'm monitoring that, and so I can ask the question to the presenter. So don't be shy, ask your questions, ask away, and let's make this interactive. Second, if you want a copy of the presentation, please email us at isettmembers@gmail.com. I will also put that on the screen again, the chat box again, or you can email the presenter themselves and ask for that slide, their presentation. And then last quick reminder that you will receive asset CEUs, but please give it some time. We're going to turn in the attendee list after this meeting, so it may take up to 3 to 4 weeks. before you actually see your CUs in your transcripts through the ISETT website. Okay, that's all the notes I have right now. Let's take a break. See you back at 12:30 sharp, where we will introduce Dr. Miller and complete the afternoon section of our webinar. Thanks, guys. See you soon.
If I could just add two more things before we let go.
Sure.
If your name that you entered for the for logging on is not the name of your ISETT account, please email us or let us know some way so that we can make sure that you are checked off for your attendance here. And then secondly, if you guys want to take some time during your break to brainstorm or make some suggestions about the upcoming year, things that you might like to see, things that you maybe want to add, or things that you liked about this year that you want to see continue forward, or any new ideas, or people that you may want to nominate for the board, we can just kind of have like an ongoing chat if you guys want to type in there. We would love to hear your opinions and your ideas and requests for what we can provide for you guys in 2021. Other than that, if anyone has any questions, if not, we'll go ahead and break. All right, thank you guys. Enjoy your lunch, and we'll see you at 12:30.